Good evening, ladies and gentlemen, and esteemed panelists. I'm on a bit of an angle here so that those on this side of the room have a better view of our panelists. Paul, who was one of the last to come in, said, "Boy, you really know how to bring a crowd out." I said, "Yeah, don't charge." Tonight's town hall has been some time in the making, I can tell you, and I'm glad we could all come together tonight and have this very difficult but very important discussion. I've always been so proud to represent a community that is willing to inform itself and engage in discussion on difficult and contentious issues. And few are as divisive as how we deal with end-of-life issues. I'm certain that if we polled the audience, many, if not most attendees would have a first-hand experience of a loved one or family member who suffered from a severely debilitating or terminal illness. It's emotional. There's no question about it. And everyone has some sort of opinion on the issue, one way or the other. My story involves my own father, Miko. A vital and active man, he developed Alzheimer's, fundamentally changing his quality of life and the nature of his relationship with my mother, my brothers, and my sisters. It's impossible to live through an ordeal like that and not consider any number of options. But I'll tell you that as terrible as the disease was, the whole experience ultimately drew us that much closer to him, and our family that much closer to each other in ways that we could not have imagined. Much of what I experienced during that trying time became the subject of an ad hoc parliamentary committee on palliative and compassionate care, which I founded with my colleagues several years ago, Joe Comartin, the NDP MP for Windsor West, and Harold Albrecht, the Conservative MP for Kitchener-Conestoga. What was imparted on me most from hearing from hundreds, literally hundreds and hundreds of witnesses, individuals speaking on their own behalf, professionals of every range, organizations that either came to Ottawa or we went across the country to hear, is that there is a significant difference made when one is allowed to live with dignity and not feeling like one is a burden on family and friends or society, given a reason to live and relatively pain-free. Now, that was my experience, and the experiences of others may in fact be quite different. I know that. What has been made clear through famous cases like Sue Rodriguez, Gloria Taylor, and most recently Susan Griffiths in Winnipeg, as well as during the debate in the House of Commons on Francine Lalonde's assisted suicide private members bill, is that we cannot inform ourselves on anecdote. And that's important. We must inform ourselves on deeply controversial issues like this in many different ways. Some by faith alone, others by science alone, and many by a combination of both. Some of us need to expand our viewpoints, and with us tonight are four very esteemed panelists, each an expert in their respective fields, and frankly, we're lucky to have them all in Guelph, who will challenge our understanding of the issue and help us understand the issue that much better. So with us tonight is Dr. Marnan Heisel, a clinical psychologist whose research focuses on the assessment and treatment of depression and suicide risk among older adults, and investigation of associated risk and resiliency factors. To date, this program of research has contributed a novel measure of suicide ideation among older adults. Ideation, for those of you who, like me, didn't understand and had to look it up in the dictionary, is the process of forming ideas or images. So, suicide ideation among older adults, called the Geriatric Suicide Ideation Scale. He assessed the psychometric properties of existing measures of late life depression and hopelessness, hopelessness, investigated cognitive and personality vulnerability to depression and suicide risk, explored meaning in life and other psychological resiliency factors, and included a psychotherapy treatment study for older adults at risk for suicide. Dr. Carrie Bowman has a PhD in bioethics and a fellowship in cultural psychiatry and master's in social work. Dr. Bowman is currently the clinical ethicist at Mount Sinai Hospital and teaches at the University of Toronto. He lectures and publishes widely on ethics in healthcare, reproductive ethics, end-of-life care, cultural diversity, conflict resolution in healthcare, genomics, and emerging medical technologies. He has consulted extensively on these topics in Germany, Iran, South Africa, and the People's Republic of China. Also with us is Dr. Greg Robinson, a retired physician who practiced family medicine in the area of palliative care and as a public health doctor and researcher. He brings a particularly unique perspective to this debate as he is terminally ill from the side effects of the drugs he has taken in his battle with HIV/AIDS, a disease he contracted over 30 years ago. A lifelong advocate for social justice, he is involved in the advocacy movement to bring humane treatment to those dying from HIV/AIDS. He sees expanding end-of-life choice as the most significant social justice issue of our time and stands with the 75% or so of Canadians who support allowing medical aid in dying for the grievously ill who have intolerable and unmanageable suffering at end of life. And last but not least, Wanda Morris. Wanda is the Executive Director of Dying with Dignity Canada, a national charity with over 2,300 members and supporters founded in 1980 to improve quality of dying and expand end-of-life choices. Wanda has been active with the Dying with Dignity movement for many years. In 2010, she presented to the Parliamentary Committee on Palliative and Compassionate Care, the one I spoke of earlier. In 2011, she provided testimony in the Dying with Dignity Charter Challenge brought before the Supreme Court of British Columbia. Now, I will be the moderator. It's not my job to convince anyone here one way or another, but to facilitate a friendly, respectful, and informative conversation on this important topic. And I look forward to the rest of this evening. Now, each of our panelists will speak for about 15 to 20 minutes, after which time you will be invited to one of two microphones. I'm not sure where they're located. Oh, they're back here. Okay. Back there, behind us. You may make a comment or ask a question, but in fairness, it should not exceed 1 minute. 1 minute's a long time. I have to ask a question in question period in 35 seconds. So think about your question and edit it down to a minute, or your comment and edit it down to a minute. It should be directed to a particular panelist. So I would ask you to direct your question, if it is one, or comment. If you want to direct that comment to a particular panelist, do so. That panelist will respond, and afterwards, a person with we'll say, a varying opinion will have an opportunity to respond to that person's answer. So, according to my list, we are going to start with Dr. Greg Robinson.
Can everybody see me and hear me from up here? Good. Good evening. He lay there weakly gasping for each breath as his reserve for life waned. He was passive, totally dependent on us, his care team, to attend to his every need. His body was grossly distorted and swollen with lymph glands that protruded from his emaciated frame. This was AIDS before life-saving medications were discovered in the 1990s. This and Kaposi sarcomas, those ugly black-purple skin cancers that stood out like beacons, and announced one's affliction with AIDS, and lymphomas, and wasting disease, and pneumocystis pneumonia, and other life-ending and intolerable illnesses. Now his lungs were filling up painfully as the pneumonia worsened. The gurgling, wheezing, rasping was at times heavy, but when it was light, we held on edge for his release. He had not talked in a day, although his eyes opened lovingly. One could still see the pain held within. Anything we tried to put in his mouth, including pain medication, was drooled out within seconds. He began to suffer critically, and it overwhelmed his meek and mild demeanor. We would soon lose him forever, and I would be a widower at the age of 36. Life was reduced to a cruel joke. I was sure I was the next to go, and I was determined not to allow myself or another person to suffer at the end of life. That was the day I went to his doctor and got injectable morphine, and there were a few uncomfortable obstacles along that route, even for a physician such as myself. Once procured and in hand, I injected morphine into his dehydrated, laxed skin often, very often. Within a day, he had passed away, but he remained unconscious mostly during those final hours. I would not say his death was peaceful enough, pain-free enough, comfortable, or even easy after morphine injections. By that point, he'd already suffered enough. And to me, that is the point. We've all witnessed and experienced loved ones, friends, and others who have suffered enough. Even with excellent palliative care, sometimes death with medical assistance is desired and required to end the suffering. In fact, to me, good palliative care includes the option for medical aid in dying. AIDS was my introduction to the ugly and undignified side of death. True, as a doctor, I had seen death, treated patients who were dying, and I saw the best and the limits of my medicine and even the best palliative care. But I had not witnessed death like this, for it was too close to heart and home. We were too young. There were no drugs to save us, only horror, pain, loss, and grief, day after day. The horrific effect of AIDS brought many gay men in the 1980s to confront not only a young death, but a painful, ugly, and terrifying death. Suicide became a real option for those diagnosed with AIDS in the 1980s. Like others with AIDS, I had my own stash of secobarbital to take, and I would have. I'm one of the very fortunate persons who lived to see a day of new AIDS chemotherapies. Thus, we are often called Lazarus survivors. I know the value of life, and I cherish each day. But when it is over, I want all choices for a peaceful and dignified death available to me, including excellent palliative care and the choice for medically assisted dying. 6 years after losing Blair, my spouse, I lost my father. I'm still haunted to this day with the call of my dad's desperate voice. "I'm still here," he queried in his groggy state. We had no idea why, with blood cancer, after weeks of refusing blood and plasma products, not a blood cell to his name, life still hung to his frail body. And now he was resenting the wait after 2 months of an in-hospital palliative care. It haunts me because of his reliance on me as his physician's son and his request to see Dr. Kevorkian. This was Windsor in October of 1998, and the passionate doctor of euthanasia was reported to be just across the border. While my dad made no bones about mentioning it to me, he was much more reserved with others in my family given their strong Christian values. I think he knew that I held very liberal beliefs on medical aid in dying after years of watching my friends and lovers die of AIDS. I was devastated when my father's pleading to beg for release In desperation, he had asked me to hasten his death. I was the doctor. I was the son. My heart was torn apart, knowing that I could not grant that which came to me most naturally, to comfort and release my father from the suffering. After hearing of my dad's plea that day, I reassured him that I would let him go to sleep and not wake up if that's what he wished. I was able to negotiate deep, continuous palliative sedation with his physician. He passed away very restlessly within 24 hours. The horror of this was entirely unnecessary, and it left permanent scars on our lives. Some of you may have similar stories. Our compassion now needs to extend our palliative care to include medical aid in dying when needed and desired. We must end inhumane suffering at the end of life. We often hear that we should not proceed due to the potential for abuse with the most vulnerable in society, the elderly, the disabled, people living with HIV infection, for example. Yes, these are valid concerns, and it's certainly why I want to be at the table when legislation is drafted. Wanda will cover the evidence that supports medical aid in dying from the abundant literature on countries and states that have legalized it. There are a couple areas where, as a physician, I can shed some light, and that is about capacity and consent to treatment and clinical depression. As a medical practitioner, one of the skills I used every single day was assessing capacity. Was the person able to give informed consent, whether it was to a treatment, a diagnostic procedure, or an examination? This is something doctors become very adept at, and we have to be. While not infrequent, there are times in every physician's practice when a patient says they want to stop or decline a treatment that means the difference between life and death. Whether that treatment is CPR or feeding tubes or amputation of a diseased leg, every one of these decisions is a matter of life and death. And we have to be sure that a patient is competent to make those decisions. Those who oppose end-of-life choice will sometimes assert that it is not possible to determine if a patient is clinically depressed and thus has impaired decision-making. This is simply not the case. While it may not be possible to be 100% certain that someone is depressed, a physician can identify certain risk factors and key clinical features and realize when a further mental health assessment is required. I believe that all persons who request medical assistance in dying should undergo a mental health and capacity assessment with a psychiatrist, along with a complete assessment from their attending physician. I think we just have to look from the data of the Netherlands to see the results of the depth of the screening processes that can take place. Only 1/3 of individuals in the Netherlands who seek to have assistance in dying have their request granted. As a family physician, I have always tried to provide compassionate and non-judgmental care with full respect for patient autonomy and informed choice. As a public health physician, I have always been committed to correcting inequities and determinants of health so that health care is accessible to all and optimal wellness is achievable. All Canadians must have full access to hospice, palliative care, and all end-of-life measures. As an AIDS activist, I have always fought for patient choice in care, treatment, support, prevention, and rehabilitation. Choice in all matters of life and death. I am now facing the end of my life with AIDS, cirrhosis from chemotherapy, cancer, diabetes, osteoporosis, fractures, osteonecrosis of the knees, and it goes on. Some days I marvel at just how far I get with this vintage model. But now I'm in desperate need of some new parts. Knees and liver top the list right now. I've had just about every procedure in the textbooks done to my body. Dignity is very hard to maintain after years of being stabbed and jabbed with needles and tubes, being propped into pornographic poses with no clothing on, having diarrhea pour down your leg in public, vomiting so much that it hurts, and physical pain 24 hours a day. What I need now is the comfort and the choice to determine all health interventions I may wish to have to ease my uncontrolled suffering during my death. This includes access to medically assisted dying if I choose. Just knowing that I would have the option grants me peace of mind. Speaking up in favor of medically assisted dying, and you have the power to grant Canadians, like myself, this gift of peace. Thank you.